I'm Rebecca Bowers, DO, and in this video I will be discussing how to treat cylinder distortions using facilitated oscillatory release. This allows you to more quickly treat cylinder distortions, even deep ones, without the need for a suction device or other tools. For those who may not be familiar with a cylinder distortion somatic dysfunction, it is one of the 6 types of dysfunctions of the fascial distortion model. It is described as the overlapping of cylindrical fascial coils. While sometimes it may be necessary to feel for the abnormally tight coils, often you can palpate for dysfunctional tension of the whole fascial cylinder, as tension of the coils causes the cylinder to become taut. Often a patient who has a cylinder distortion will describe pain and uncomfortable sensations like numbness, tingling, a sense of swelling, or sometimes a tremor, and the symptoms described will not fit a radicular or entrapped nerve pattern. Typically, when a patient describes a bizarre constellation of symptoms in a body part, I look for a cylinder distortion, and they often have one. This picture is from a patient of mine who presented with something wrong in their left leg. They had had chronic intermittent low back and knee pain, but for the past month their whole left leg felt numb and swollen, and the patient said it hurt but could not describe the pain. Sensation was normal on exam, and there were no signs of swelling in the leg, but there was a cylinder distortion of the periosteum of the left femur. In the following video, I will show how one might palpate for cylinder distortions in a patient's thigh. Keep in mind that a cylinder distortion might be in a big superficial compartment like the fascia lata, or a smaller, more deep compartment like even the periosteum around a bone.
So finding a cylinder distortion in the thigh, for example, in his left fascia lata, we can look and see if there is a cylinder distortion. I'm going to move the leg out just a little bit so I got room, because what I want to feel for is that a whole cylinder, it's tight on every side. So compress into it and then move side to side. I usually get my hands on opposite sides and I just do a back and forth motion, which is a useful way to palpate for cylinders in a lot of areas in the body. And then once you determine that it does feel like all the way around, there's this tightness, kind of like a trampoline, that when you spring into it, it's just taut all throughout. Then, and this is the important part for using facilitated oscillatory release to treat these cylinders, is you have to find which side has the maximum tension. There's going to be a line of maximum tension. So if I palpate around here, I still feel that taut feeling. But when I get posteriorly and I press up in, there's a line about yay big, maybe an inch across, and it goes the length of the cylinder. So that's that side of maximum tension posteriorly for him.
Now that we've found a cylinder dysfunction and identified its side of maximal tension, let's discuss facilitated oscillatory release. Inspiration for the technique I am about to show you came from this book by Zachary Comeau, in which he describes the principles of facilitated oscillatory release and shows how one might apply facilitated oscillatory release to different parts of the body. As the name implies, facilitated oscillatory release uses an oscillatory wave to release somatic dysfunction. It is most often applied in a direct fashion because taut tissues better propagate waves than do loose tissues. Think of how a loose guitar string needs to be taut in order to vibrate with sound. The first step then is to increase the tension in the tissues that are to be treated. Then introduce a wave so it travels down into the dysfunction and bumps it free. When using facilitated oscillatory release to treat cylinder distortions, it's important to palpate for the side of maximal tension. In this example, the posterior aspect of the fascia lata. While cylinder distortions have tension all around the cylinder, there will be a linear area of increased tension on just one side, and this is what we will aim the facilitated oscillatory release at. First, elongate the side of maximal tension to draw those tissues even more taut, then introduce an oscillatory force from one end of the cylinder to whip it free. The release is near instantaneous. Let's watch me treat a cylinder distortion of the fascia lata.
So now for treating this cylinder distortion of his left fascia lata using facilitated oscillatory release, what I want to do is I want to put tension along that line of maximum tension, which in his case was posteriorly. Like so. And then you want to introduce an oscillatory wave down from either end. In this case, it's going to be easier to introduce it through up here down in than it is for me here. So I create that and exaggerate and pull on that line of tension and a little wiggle, and it just resolves itself. And of course, you can go and recheck. And you no longer have that taut cylindric tension, and definitely that maximum line of tension is gone as well.
As previously mentioned, for my patient with the difficult to describe pain and alteration of sensation in the whole of their left leg, I actually found a cylinder distortion of the periosteum of their left femur, and the side of maximal tension was posterolateral. I know this was a cylinder and not some other interosseous strain because of the way the periosteum felt like two tight pantyhose compressing the shaft of the femur. After I treated this patient's femoral cylinder distortion with facilitated oscillatory release, she had complete resolution of her left lower extremity symptoms. Now let's watch as I show how to modify the setup in order to treat a cylinder distortion of the femur that has a posterior side of maximal tension.
If instead the cylinder distortion had been in a deeper structure, say the periosteum around the femur itself, I am going to have to adjust my handhold so that I can really make sure that I get in there and press that cylinder so that it elongates on that side that's tight. So let's imagine for him that the femur actually has the whole periosteum around it tight, but the maximum line of tension is still posteriorly back there. So in this case, I really want to make sure that I am bowing out that line and elongating that maximum tension posteriorly. So I'm going to hook under the femur and then add a compressive force anteriorly. And then this hand here, or this arm here that is more distal, I'm going to give it a little shake and it would resolve if he had one.
I have made this video as a resource for other physicians and body workers. Do not attempt to perform any manual techniques unless you are a physician or body worker or a student under proper supervision.